Hi, everyone. My name is Lily. I'm the Billing and Office Manager at Community Health Resource Center. Thank you for joining today's community outreach presentation, Genetic Predisposition for Cardiovascular Disease, sponsored by CPMC's Kanbar Cardiac Care Center. Today, we are fortunate to have Austin Chua, a Sutter Health CPMC Cardiology and Oncology genetic counselor here with us to discuss how genetic factors influence the risk for heart disease. Before we get started, I'd just like to share a few words about the Kanbar Cardiac Care Center. It was originally founded in 2002 at the CPMC Pacific Heights campus and relaunched at the CPMC Van Ness campus in 2022. The center was formed by the generous contributions of the late Maurice Kanbar, who was an inventor, innovator, entrepreneur, but more importantly, a philanthropist. The Kanbar Cardiac Care Center is one of the highest ranking cardiac health facilities in California. It offers an array of cardiac services and specialists who use advanced technologies to diagnose and treat patients with heart disease. Its nationally recognized physicians, surgeons, and clinicians are committed to providing excellent personalized care in a contemporary and welcoming setting. As a reminder, the information provided in today's presentation is for educational purposes only, and it's not a substitute for professional medical advice. And with that, I'll go ahead and pass it along to Austin to introduce himself and dive into the presentation.
No, thank you for everybody for having me, and thank you for Kanbar for inviting me to chat a little bit about some of my passions, which is genetics and how that might help folks. Today's discussion is really going to be surrounding specifically genetic predisposition for cardiovascular disease. Like Lily mentioned, I'm Austin. I'm a genetic counselor. I've been working with Sutter for a few years now on both the cardiology and oncology side of genetics. Today's discussion will be reviewing how genetics can relate to some cardiac conditions and seeing how a genetic counselor, someone like myself, might play a pretty vital role during a testing process for someone that might have a possible hereditary predisposition to cardiovascular disease. So with that being said, let me just go to the next slide here. No conflicts of interest to disclose for our chat today. And a little bit about me. Like I mentioned, my name's Austin. I've been in and around the Bay Area all my life. Did undergraduate at UC Davis for biotechnology. And then during that time, I realized I wanted to work more with patients instead of in the lab, and did a specific master's for genetic counseling for CSU Stanislaus Bay Area based program for genetic counseling. I've been board certified since 2020. Much of my career has been at Sutter Health so far since 2021, working with the oncology side of things. About a year and a half in, my manager said, "Hey, how do you feel about taking on some cardiology genetics?" So that was a learning experience for me. And since then, been really working with Sutter to help grow a lot of cardiology and the cardiology side of things. All right. So yes, cardiogenetics, a pretty overarching word that can really encompass a lot of topics. But before we get into a lot of the nitty-gritty of what cardiology and genetics, how they sort of link together, I think it's really important to first have a good solid grasp of sort of base level of genetics knowledge. With that being said, I sort of wanted to take a look at that bigger picture. Here is this cartoon representation of essentially cells and DNA. On the left here, we have my little laser pointer here, a cell, and this, I'd say, diagram is something we'll reference throughout our discussion today. But on the left, this yellow blob, I like to think of it as like a cell. It's essentially the building block for the human body. Your eyes, your skin, your nails, all your organs, everything is made up of these little building blocks in their own form and shape. Now, at the center of these building blocks, there is this little purple circle here. The cell is comprised of a lot of different organelles or different aspects of the cell. This is the one that we're going to focus on, this little purple blob. It's what we call the nucleus. This nucleus holds all the genetic information in the human body. Now, if we sort of zoom in and we see those little X-shaped structures housed inside the nucleus, if we zoom in and look at it, it's what we call a chromosome, this little X-shaped structure here. We can think of this as essentially DNA wrapped up really, 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 really tightly and condensed into this form that allows the cell to really pack a lot of information into a small place. As we can see, it's sort of strung out here. And if we string it all out, we eventually see what we come to know as DNA. All right. Now, this picture is sort of a real life representation of what chromosomes actually look like under the microscope. So those little X-shaped structures, if we go in and extract them from that nucleus, they sort of look like this left-sided blob here of just genetic information. And scientists are able to actually line up different chromosomes that are known and identifiable based off of their banding pattern. So we can see here, they're nicely lined up here. As you may see, there's 23 pairs of chromosomes. If you are all familiar with 23andMe, similar to how 23andMe sort of has drawn their name from is essentially these pairs of chromosomes. Okay, so back again, looking at this picture, we can see that a single strand of DNA is very, very tightly wound up, and that makes up all these X-shaped chromosomes that I showed in the previous picture. Just an interesting small fact. If just one cell's DNA was sort of unwound sort of in one strand, it would really be a singular cell's DNA would be over 6 feet long. Current estimates say that the human body is made up of approximately 30 trillion of these little yellow blobs on the left. So if we line up everyone's DNA, or just one person's DNA, excuse me, end to end, it would really be enough to stretch all the way to the sun and back down to Earth and back multiple times. We could really go through a whole separate lecture about the single marvel of how the human body is able to pack so much information into such a small area. But we're going to focus on just the sort of cardiology side of things. All right. Now that we have sort of a base level of sort of how DNA is stored, what exactly is its function? DNA acts as the genetic information found in our cells. Cells will read this DNA using specialized protein machinery, which encode for other different proteins have different functions in our bodies. Each gene or instruction varies based on how these 4 nucleic acids that are on that picture are sort of laid out. So these A's, these T's, these C's, these G's, they stand for adenine, thymine, guanine, and cytosine. Their specific order and combination is what gives rise to not only a normal functioning gene, but also the gene's variability. For instance, I have perhaps genes that encode for dark colored hair, whereas another person may have differing genes or different changes in these genes, which may encode for something like brown hair or blonde hair, etc. What exactly is a gene? Sort of listed there, segments of DNA along these chromosomes that encode for different specific functions within the body. All right. Now, next slide. That's all fine and good, but you can imagine just how much DNA the human body has. We sort of went into sort of the vast swath of DNA that just one cell can carry. Because of just the sheer volume of DNA and information that DNA has and that genes themselves can carry, what can happen when one of these changes or variability can occur that doesn't really act as just variability, but more so affects the actual function of the gene itself. That would be something that we would call a mutation. Okay, in this picture, a mutation is highlighted by that little glowing piece there. Mutations don't actually glow, but just sort of just to highlight that that's what sort of can happen in the gene. A more cartoon representation is shown here, but I just wanted to mention that these mutations would not allow these genes to function to their sort of full capacity, if you will. Okay, so a mutation changes the function of the gene. This is, like I mentioned, another cartoon representation. An example of a gene could be the bottom line here. So where normally it would say the red fox jumps, a genetic change or a mutation could cause the gene to now read the red box jumps. Okay, now the mutation I mentioned could sort of be represented by that little explosion there, but when we think of the red box jumps, we think of, okay, well, it's still getting the main point across of, something's jumping and something's red. And the human body can sort of work its magic to sort of guesstimate the rest of it and still have a pretty good function, a grasp of the function of that gene. What may change is if we think of this sort of bottom type of mutation, if you will, a different sort of variation, where instead of the red fox jumps, we sort of get into the red. And if that letter P might just signal for the gene, the protein machinery to just stop reading. So at that point, we're sort of missing this last half of the gene. We don't really know, the body doesn't really know exactly how it applies and what its function should be. So we can take that and say, well, if we can apply that to the rest of, or proteins and genes that we know have a very vital function for the function of the heart, we can imagine how this can sort of alter heart function eventually as well, right? Next slide. Okay, so the heart, we're all fairly familiar with the heart's function, right? Responsible for pumping blood throughout our bodies, carrying fresh oxygen throughout different organs and muscles, while still cycling the not so fresh blood to our lungs, and sort of cycles repeated on and on and on again. A lot of things can really depend on the heart's successful function. As we listed out there, right? The heart muscle itself needs to be functioning nice and gracefully and pumping that blood. The electrical rhythm, how the heart beats, how the electricity is signaled through the heart can alter heart function as well as having these unblocked vessels, right? If there's plaques or different blockages in the heart arteries can affect how efficient the heart may pump a lot of that blood, okay? So there's a lot of genes that can directly or indirectly affect these aspects. However, other things can also get in the way. So not only are we thinking of these conditions as mostly occurring through not genetic function, the majority of them are not actually related to genetics. Heart disease, for instance, over 370,000 people in the USA die from coronary heart disease just in 2022 alone, and over 805,000 people have a history of heart attacks annually. For arrhythmias, when we're thinking of heart rhythm disorders, atrial fibrillation is a quite common type of arrhythmia. Atrial fibrillation affects estimated about 2.7 to 6.1 million people in the USA alone. Who knows what that number could be worldwide? Heart failure, over 6.7 million adults over age 20 have history of heart failure, okay? Now, when thinking about heart disease, things like diet, exercise, lifestyle may play a huge role in coronary heart disease. For arrhythmias, things like as simple as electrolyte imbalance may cause someone to develop an arrhythmia or sort of palpitations, etc. Heart failure, high blood pressure, other heart muscle conditions, obesity, smoking can also cause someone to develop heart failure as well. But it's also important to emphasize that although my slides keep jumping. Although it's important to emphasize that a lot of these things are not caused by sort of a solely genetic cause, there is a small portion of them that do have a hereditary component as well. Now we can go to the next slide. So I just wanted to put this slide out here to show you that these are some indications that we see specifically in cardiology genetics. On the top left there, arrhythmias, electrical system disorders. On the top right, cardiomyopathies, specifically heart muscle conditions. The first one under the cardiomyopathies, hypertrophic cardiomyopathy. That's an example which I'll talk about a little bit later today. We'll bring up a case example as well. We'll actually look at a family history of someone that we've seen with the history of hypertrophic cardiomyopathy. So keep that one in mind. Bottom left, familial hypercholesterolemia, when folks have a history of sort of genetic high cholesterol, if you will. This leads to really, really elevated early onset of coronary artery disease and high risk of stroke and heart attack as well. This is a big one, thoracic aortic aneurysms and dissections, when someone's aorta can become a lot larger as well. So like I mentioned, I just bring this one up just to say again that although the majority of, or I'd say the minority of these conditions are caused by genetic predisposition, the majority are caused by other factors as well. So like we mentioned, right, arrhythmia is caused by electrolyte imbalances, but also hormonal changes, different medications, smoking, alcohol, caffeine, there's different compounds as well. For cardiomyopathies, even certain viral illnesses, long-term high blood pressure can cause cardiomyopathies. And for familial hypercholesterolemia, someone may say, well, hey, my family's got a really, really high family history of high cholesterol. There are other things that can cause high cholesterol as well, as everybody is aware, right? Diet, lifestyle, exercise, etc. All right. Now, so let's take this. I mentioned hypertrophic cardiomyopathy. We'll call it HCM, just as an abbreviation. Let's just take that as an example. One of the more common indications that we see in our cardiogenetics clinic. In the general population, it is found to be one of the most common hereditary cardiac conditions. About 1 in 500 individuals in the general population may develop HCM over their lifetime, where the muscle of the heart actually becomes a lot thicker than usual. Okay. And when the muscle becomes a lot thicker, this doesn't allow the heart to pump blood as efficiently as it normally would be able to. Some studies even put this 1 in 500 number even lower, so even more common than 1 in 500. There's numerous genes that can cause hypertrophic cardiomyopathy in a hereditary fashion. This mostly sarcomeric proteins, especially myosin binding protein and heavy chain myosin. These are essentially proteins that help the heart to contract. So if these are sort of mutated, they can get out of whack. The heart can start to show signs of actually becoming a little bit thicker and showing hypertrophic cardiomyopathy. This third line here is going over how differential diagnosis. There's actually a lot of other conditions that may cause someone to develop hypertrophic cardiomyopathy as well. Things like Fabry's, Friedreich's ataxia, with amyloid as well, which are hereditary conditions, but even things as simple as long-term high blood pressure here can also cause hypertrophic cardiomyopathy as well. This is a big thing that I want to keep an eye on here, positive genetic testing. Most commonly, we would have a positive genetic test if someone presented at a very young age. If the thickness of their heart was particularly large, if they had a positive family history of sudden cardiac death, and it wasn't caused by, or they didn't have a personal or family history of hypertension as well. Okay. So hypertrophic cardiomyopathy. Let's take sort of knowing that, where do I fit in? After this, we're going to sort of bring up that case example, but the role of a genetic counselor. Where do counselors fit in? Where do I come in during someone's sort of genetics journey? Genetic counselors are very specialized in medical genetics and counseling to help physicians and patients translate a lot of these complex medical terms and science into really practical decision-making information to help ensure best patient outcomes and patient satisfaction. That's all we want, right? So the first box here would be right here, identifying appropriate patients for genetic counseling, something your doctor, your PCP, your cardiologist might identify who might be appropriate patients for genetic counselors to actually see. Does somebody have a very strong personal or family history that looks particularly suspicious for a genetic predisposition? In that case, they would say, yep, you qualify for genetic testing. You should probably go see one of these counselors. They would send over a referral form, or a family member would come see us within the cardiac genetics clinic and actually get that genetic testing process started. That's when that second box would come in, where that detailed pretest counseling, that's where I would come in, right? The second box. I would be that one doing that pretest counseling with folks, doing a lot of patient education, talking about the pros, the cons of genetic testing, what these results might mean, how might they be applied to someone's care itself. And that's what we would sort of do during the first genetic testing appointment, actually selecting the best test appropriate possible during the appointment, and which one may be most applicable for the symptoms at hand. Is it a cardiomyopathy panel? Are we really worried about maybe aorta conditions or arrhythmias? Maybe both. That's when we would sort of tackle what test might be best for the patient. Next would be actually, when we actually get those results, what might those results mean? Are there any variations that might be particularly suspicious or very indicative of what's going on in the personal or family history? Do we have an answer of what's going on in the family? Do we not have an answer? Really tackling that question is that second to last box, the post-test counseling, results disclosure. I would contact all my patients directly and actually talk about what those results mean. So here's a spoiler. This is sort of what we would talk about in the family history itself and get this family tree. Once we have identified appropriate patients for genetic testing, we would see them for actual genetic counseling, genetics education, talk about what those results might tell them, what their family history might be. We would draw that down on this family tree here. So I want to sort of use this as sort of a little mental exercise for us. We're going to take a few minutes just to take a look at this particular family tree pedigree here. This is a particularly typical family history of a possible hereditary hypertrophic cardiomyopathy patient. So a quick rundown of how we actually read these family trees. Our patient here is our bottom left, the guy with the little arrow here. And males are in the squares and females are in circles. So we know that this is mom's side of the family here, dad's side of the family here. If they're colored in, they probably have some sort of symptom. So HCM, that stands for hypertrophic cardiomyopathy. So what I just want to do is take 2 minutes. I'm just going to time out 2 minutes. We're going to take a look at the family history, see what we can gather. If there's any particularly suspicious points, note them, and see if they particularly apply to some of the points that I noted on the left. People passing away quite suddenly, unexpectedly, younger ages of diagnosis, and maybe if there's multiple generations affected. Okay, so just take a couple minutes. I'm going to time it out, and then we'll sort of come back and we'll sort of talk through about what some of these particular signs that we're looking for as counselors in this family tree would be, right? Okay. All right, so let's go to this next slide here. So let's review on some points that we might have picked up when reviewing some of this family history. So our patient, that square in the bottom left, diagnosed with hypertrophic cardiomyopathy at only about age 23. So really, really young diagnosis of hypertrophic cardiomyopathy. Looks like not many other symptoms, exercises regularly, but still looking at the family history, we might see other suspicious signs, especially what's on that right side of the family tree. Mom's side of the family, we can see the circle to the upper right here. This is mom. It looks like she had passed away in her 50s because of SCD, sudden cardiac death. She was diagnosed with hypertrophic cardiomyopathy at age 14, so even younger than our patient. Looks like she was diagnosed with LVH, a history of LVH, this left ventricular hypertrophy. It's a very classic sign of hypertrophic cardiomyopathy. Also, even looking past just our patient and mom, we see that mom's sister right here. Mom's sister, age 54, diagnosed with hypertrophic cardiomyopathy, again, at quite a young age, 26, had an ICD, implantable defibrillator, implanted at 49 to help her deal with increased risk for something like a cardiac arrest. Okay. And then we can even look further and say, wow, okay, mom's mom right here, she had some sort of history of heart failure, as well as diagnosed with atrial fibrillation, had a pacemaker, and boom, HCM also diagnosed. HCM also seems to be diagnosed in a lot of other sort of grandma's relatives as well. So we can see that really it's been running in the family right now for quite a bit, quite a long time. We can check a lot of these boxes here on the left side. People passing away quite suddenly, unexpectedly. For mom here, younger age of diagnosis applies to multiple family members and multiple generations affected. These are all classic signs of a hereditary predisposition to a hereditary cardiac condition like hypertrophic cardiomyopathy. Okay. Now, so that patient did genetic testing and actually got positive genetic test results. So let me just put back right here. So this was the actual gene of interest, MYBPC3. That is one of the more common genes associated with hypertrophic cardiomyopathy. Our patient did genetic testing, was found to be positive. Essentially, what now? What do we do with those positive results is the big question that a lot of questions might ask. Uh, some big questions, I think, some interesting points to note. Post-genetic testing, that sort of fourth box that we talked about, post-genetic testing are above, right? Is it really a really interesting point I tackle with a lot of folks is how would you actually view positive results? I've heard really ranging reactions from, oh my gosh, this positive result, it's going to be a death sentence, to folks actually saying, positive result, that's great news. Some might see a genetic mutation as really unexpected, whereas especially with a family history that's not as strong, but with some that might have a really strong family history, they might finally feel that their journey to find what's the root cause of so much of the family's cardiac problems, we've got an answer finally. Second question might be, what now? For a lot of these cardiac diagnoses, even arrhythmias and cardiomyopathies, even if someone was positive, like our patient, it may not be of too much consequence to their current personal care if they already have certain symptoms. Okay. Cardiac care for something like HCM, for example, usually doesn't change whether or not a mutation is found or not. In some cases, though, it may. For a really advanced disease where doctors, cardiologists might be thinking about transplant even, or certain cardiac devices might assist, cardiologists may take genetic results into consideration. Okay. Sometimes we get the question of, well, then, why is genetic testing actually needed? In many cases, testing still warranted just because of the rest of the family planning as well. So children, siblings, parents, and I mentioned children, maybe future children as well, may benefit from genetic testing. The actual identification of a known familial mutation really helps clarifies one's own risk in the future to develop cardiac problems down the line. In these scenarios, putting someone on a more regimented screening program, like doing more echocardiograms or EKGs, if there's a known familial mutation, may help cardiologists and the patient track any progression of their cardiac symptoms over time. All right. Rising awareness. So there's been a lot of TV and radio commercials that I've noticed, at least within the past year, that talk, hey, if you have a family history of hypertrophic cardiomyopathy or amyloidosis, et cetera, more and more of these spotlights of on cardiac conditions has raised a lot of awareness, increased recognition. Research has really blossomed in the last few years. These days, increasing number of pharmaceutical companies have targeted cardiac medications. Years ago, for instance, I'm going to use another type of cardiomyopathy as an example, hereditary amyloidosis. Years ago, it really wasn't even a thing. Back then, amyloidosis was probably a hereditary cardiac condition, but folks, if they actually had it, weren't really properly diagnosed. Might be chalked up to something like, oh, their heart gave out, or just heart failure, if you will. Rising awareness research has allowed us to make more connections and actually, okay, thank you, actually allowed us to research gene-specific treatments. These days, medications like the ones I've listed on the left side, patisiran and tafamidis, are really more actually very recommended in the case of a hereditary amyloidosis, okay, and are very effective, may even reverse some cardiac symptoms for a lot of folks that do have these conditions already diagnosed. All right. Sometimes, and I bring up insurance discrimination with all the benefits of genetic testing that we might have reviewed, some people still ask, well, what are some of the cons of genetic testing? Something that I think, is a very personal consideration is the actual anxiety of learning some of these results, emotional distress about some of these results as well. In some cases, insurance discrimination as well, which is the focus of this slide, may also cause some people to take some pause and take some time to think about actually doing genetic testing as well. So good news is that there is some legislation out there that aims to help protect us from such discrimination. That law is called GINA. What is GINA? Genetic Information Non-Discrimination Act is a federal law that helps protect people against genetic discrimination in health insurance and employment. Genetic discrimination is the misuse of genetic information. So we know that for all health insurance and employers, they cannot use this information against you. Things like hiring or firing or raising your healthcare premiums, all very illegal based off of genetic information. It is also, unfortunately, doesn't cover certain types of insurances, things like long-term care, disability, life insurance as well. It's nice that in California, in our state, we do have more legislature that does allow for protections against life insurance discrimination. So that is nice, specifically for our state, to offer more protections against life insurance discrimination. However, GINA still does not extend to all individuals. It's not a perfect law. Veterans that get care through the VA, federal employees that have federal health plans, military members who use TRICARE don't fall under this law, are not covered by this law. So while it's not perfect, this still is just sort of a point to make, to get across that people might want to take into consideration some maybe future insurance implications before actually doing genetic testing itself. All right, but some main takeaways from today's chat is that DNA, very incredibly complex platform of human function and genetic information. Because of this complexity, there are quite a few genetic mutations which can lead to increased risk of a multitude of cardiac conditions. We talked about hypertrophic cardiomyopathy today, but really we see indications that span aortic conditions, arrhythmia conditions, genetic hereditary high cholesterol as well. And it's really, really, really important to identify those that may be at risk, because genetic medicine, something that I find very interesting with genetic medicine, is that it can not just affect the individual, but the whole family as well. Children, parents, siblings are all individuals that this can affect as well. So with that being said, those are just some main takeaways that I wanted everybody to sort of take away from today's chat. But if anyone's noted any questions, I'm happy to take those now. Appreciate your time. And we'll sort of want to take some time to not ask, but answer any questions that folks might have. I know we had some come in prior to today's chat, but if there's any as well from the chat room as well, happy to take those as well.
Wonderful. Thank you, Austin.
Excellent.
All right, let's see here. So I have some questions that were previously submitted. I'll start with those. And then, yeah, if anyone has questions here live, please feel free to enter them into the Q&A, and we'll just kind of answer them as they come in. First question, what are the benefits of having the Boston Heart Study lab done?
That is a great question. So I have actually not much experience with the Boston Heart Study. I had to look it up before today's chat because it's not actually something that's directly linked to genetics and heart disease. I just by looking it up, it looks pretty useful because it's as far as I understand, does help cardiologists gauge someone's risk for heart disease and cholesterol, high cholesterol risk. But it doesn't necessarily have that one-to-one connection with a lot of these genetic predispositions that we're really talking about. For instance, familial hypercholesterolemia, or FH, are these sort of single genetic mutations. If someone carries that, we see their HDL, or not HDL, their LDL levels and cholesterol just shoot through the roof. And because of that, have a very, very high risk of strokes and heart attacks. So I imagine there could be a large benefit of the Boston Heart Study. I can't comment on it particularly, but it could be useful.
Great, thank you. For those with genetic risk factors for cardiovascular disease, besides healthy lifestyle, are there any actions or testing that you would recommend as part of a prevention plan?
Yeah, good question. I mean, first of all, I would defer to your cardiologist. But if one actually had a sort of genetic predisposition to cardiovascular disease, in particular that condition that I just mentioned, FH, familial hypercholesterolemia, biggest thing, first line therapy is statins. So these medications have been proven to, one, reduce the risk, reduce cholesterol and the LDL levels in folks that have high levels already, and particularly for folks that do have this genetic predisposition to high cholesterol, this FH condition, it really reduces that risk of heart attack and stroke. For folks that, so for someone that doesn't have or that doesn't have this genetic change, and someone that does have this genetic change, that person that has that genetic FH mutation, even on statins, is still at a higher risk to develop or have a heart attack and stroke. So taking those statins is sort of first line therapy, number one thing that someone can do.
Great, thank you. This question, curious if you have comments on it. Why are so many young men in the South Asian community specifically having heart attacks before age 40?
That is a hard one to answer. Sort of, I think, gets within a few different points. Could there be genetic factors? Absolutely. We do know that there is at least that I've seen, there is a specific mutation that can occur in the gene that I pointed out, MYBPC3. There is a specific mutation in the South Asian population that there's more research being done on it now, so it might not be as implicated, but has been shown to be at least somewhat linked between hypertrophic cardiomyopathy and the South Asian population. I've also seen other research that things like, of course, diet, exercise, lifestyle, that may all play an influence as well. But South Asian populations also are at a little bit elevated risk for insulin resistance, and that insulin resistance also increases one's risk for heart disease as well.
Got it. That makes sense. Thank you. If you come from a family with a history of cardiac disease or cardiovascular disease, at what age do you recommend getting an assessment? And I understand there's likely some nuance here.
Definitely some nuances. I can comment on if someone has a family history of sudden cardiac death, it's just recommended just to have a heart evaluation, have EKG, have echocardiograms done every few years with a family history of sudden cardiac death. Specifically when, really depends on maybe how old you are. If you're very young when that happens, the frequency of when you receive those evaluations may be a little bit later or a little bit more frequently, really depends on the cardiologist as well. But ultimately, if you do have that history, you should probably consider having that cardiac evaluation if there is sudden cardiac death in the family.
Great, thank you. And one last previously submitted question. This one's related to Ehlers-Danlos syndrome and the risk associated with cardiovascular disease. The question mentions that they're not aware of any genetic tests for this. Do you have any insight on Ehlers-Danlos and cardiovascular disease?
Yes. So Ehlers-Danlos is a possibly genetic condition. There's actually quite a few subtypes of Ehlers-Danlos, EDS, we just call it for short. Generally, these are done through genetic testing through connective tissue disorder panels. EDS and a couple of other variations of EDS are included on these panels. Generally, though, folks won't necessarily order genetic testing too commonly for Ehlers-Danlos. It has been shown that Ehlers-Danlos affected individuals may have increased aorta diameters, especially perhaps in the teen years, but it has been shown that they don't really progress too far beyond that. So there isn't as high of a risk of actual dissection. Because of that, generally, it's not recommended to do genetic testing because there isn't much actionable screenings or things to do post genetic testing. There is one particular type of EDS, EDS type 4. It's called vascular EDS. It's a lot less common, but this is a very, very rare form of EDS where folks are at very, very high risk of dissection and even organ rupture. Pregnancies are very high risk. And in these cases, things like strokes are very common at a very young age within these hypermobile, excuse me, not hypermobile, that's another type of EDS, but this vascular type of EDS, type 4 EDS. So testing does exist out there. It's not commonly done, mostly because of the fact that there isn't much actionable screenings after doing the genetic testing for somebody.
Got it. Thank you. So Betsy's question, can you discuss, I think it's big L little pa and the genetic risk of heart disease?
Yes, so lipoprotein A, it's there is sort of research out there that shows that high levels of lipoprotein A is associated with heart disease. Generally, we don't do frequent genetic testing of these other lipidemias outside of familial hypercholesterolemia. That's sort of the big one that we do genetic testing for, mainly because it's generally controlled through statins, if anything. And in the past hasn't been I'd say it's still very new, and sort of new evidence is coming out that's saying that yes, it is linked, but there isn't much genetic testing that's done commonly because outside of statins there isn't much else to be done.
Got it. Okay. Thank you. And another question here. Can you discuss the role of the APOE gene and risk of heart disease?
Yes, ApoE gene again, kind of similar to LPA. So there's been some research as well that's shown a linkage between ApoE as well as cardiovascular disease. People may recall ApoE as well, and that's how I know ApoE is. It's also associated with sort of a risk factor for Alzheimer's disease. So there's a few things that's kind of linked with. It's actually generally not recommended to do genetic testing for ApoE. And that's a recommendation put out by medical genetics colleges themselves, mainly due to the fact that of its association with Alzheimer's disease. There's a few variations of the ApoE gene that someone may have. Some may be more protective, some may be more not protective or damaging, if you will. And when there was this big craze of people thinking about ApoE gene and Alzheimer's, like, hey, I need to do genetic testing for this to see my risk of Alzheimer's. It's not really a great predictor. A lot of people that sometimes still test ApoE and have these protective variants, it's not a guarantee that someone's not going to develop Alzheimer's. Vice versa as well. If someone has this sort of damaging variations, it's not a guarantee that someone is going to develop Alzheimer's. So in this scenario, it's giving people false hope or false reassurance, or sort of their world comes crashing down because they're like, oh my gosh, I'm going to have Alzheimer's, when that's not necessarily the case. So just based off of that, medical genetic societies have said, no, don't do genetic testing for ApoE gene. But is there a link between that and elevated cholesterol levels? Yes.
Got it. Thank
So that's
you.
sort of a long-winded way of saying yes.
Yeah, no, that's really helpful. Thank you. And I see a question here. Are there any other biomarkers for heart disease that you would like to discuss?
Heart disease specifically, no, I think the big ones that we think of are the four genes that are associated with familial hypercholesterolemia. And if someone has just a personal, or I don't know if you have a family history of, your family's cholesterol levels, but if someone's cholesterol levels go above 300, which is like very, very high in itself, that's when sort of the red alert for maybe there could be something genetic going on. Maybe talk to a genetic counselor. So if someone's cholesterol levels was above 300, that's when we would sort of want to think about that a little more. Or if someone's LDL levels were above 190, sort of same topic there.
I see. Okay, great. Thank you. And I don't know how applicable this question is, but I just saw one that I actually missed in our registration questions. Do you work at all with companies like Myriad?
Genetic testing companies, Myriad's a genetic testing company that we work with, or I don't work with them specifically. Each sort of genetic counselor will work with testing companies that they feel work well with them, or gives them, a good, list of genes that they are the most interested in, or their turnaround time, or their insurance coverage is particularly good. So we do work with these sort of genetic testing companies. It's pretty rare for genetics teams to not work with genetics companies, because having all the technology to do sequencing and all this genetic testing in-house is very, very large undertaking. But we do work with some of these genetic testing companies. Some people may have questions in the way of privacy, how that information is being stored. But we've never sort of run into any problems in that scenario. We vet all of our genetic testing companies and sort of have checks and check-ins with them regularly to make sure that they're working for our benefit and for our patients' benefit.
Great. Thank you. All right. Yeah, I'm not seeing any other questions in here. So that's, yeah, the end of today's presentation. I really just wanted to thank Austin for taking the time out of your very busy schedule to present on such an interesting topic. This isn't something that we've done a presentation on before. So yeah, really excited to be able to offer that information to the community. Thank you for joining us at the Kanbar Cardiac Care Center for this presentation. You will see a survey pop up at the end of the presentation or when you leave the presentation. We'd very much appreciate your feedback. The Kanbar Cardiac Care Center will continue to host community education events related to cardiac health every other month. So please keep an eye out for emails from us regarding upcoming presentations. Thank you all again. I hope everyone has a great evening and stay safe during this storm.
Absolutely. Thanks for having me, everybody.
Yeah, thanks, Austin. Take care, everyone.
Thank you, Austin.